Rest and sleep, the final 15 minutes. Let's try to get that done here via video. A hospitalized patient suffers from sleep pattern disturbance. To promote adequate sleep, the most important nursing intervention is to bundle our care, synchronize the medication, treatment, and vital signs schedule. Sleep deprivation, not having enough sleep, or difficulty getting to sleep, can be chronic or acute, and we know that it can cause psychological or physical symptoms. Some of the psychological symptoms of sleep deprivation include confusion or disorientation, increased sensitivity to pain, irritability. Some of the physical symptoms of sleep deprivation: fine motor clumsiness, slower responses, even cardiac arrhythmias. The parasomnias are sleep problems more common in children. Non-pharmacologic methods to promote sleep. How do we promote sleep? Besides giving patients sleep medications. We can change some of the things in the environment. Keep doors closed. Patients' rooms doors, or the doors on the areas where we're doing work on the unit. Reduce the volume of nearby telephone and paging equipment. Turn down alarms or the beeps on alarms as much as possible, while still being able to be alerted to the conditions that trigger the alarms. Avoid abrupt and loud noises. Keep necessary conversations at low levels, particularly at night. Conduct conversations and reports in private areas. Patients tell us that one of the main sources of noise that bother them and keep them from sleeping on the units are the staff themselves, especially at night. So it's really important that we do what we can to decrease the noises. For the patient outside of the hospital, we can refer them to their primary care provider for help. If their sleep problems go beyond what we can help them with through our own nursing interventions, even referral to a sleep disorder specialist might be in order. But primarily, we can help assist our patients in planning for improved sleep hygiene. Sleep hygiene, some of the elements there are to maintain a regular sleep-wake schedule, develop a pre-sleep routine, reserve the bedroom for sleep, create an environment that is conducive to sleep, avoid clock watching, limit caffeinated beverages to 1 or 2 a day and none in the evening or close to bedtime. Avoid heavy meals before bedtime. Use alcohol cautiously or in limited amounts, and avoid its use in close proximity to going to bed. Avoid daytime napping, or if nap is part of the patient's life, they don't want to give that up, no more than 20 minutes. Exercise daily, but not right before bed. Medications for sleep. There are some general things to keep in mind regarding sleep medications, and those include the fact that medications for sleep are recommended to be used on a short-term basis. And by short-term, I mean from 10 days to, say, 4 weeks for some of them. But all of them should only be used on a short-term basis. Many of them are habit-forming. Many of them are scheduled drugs. I believe they're Schedule 4 with some special considerations and restrictions for their use. Many of them have withdrawal effects if they're stopped. Tolerance develops to them. And so it's important to keep those things in mind. One other general fact that we know about medications for sleep is that, in fact, the non-pharmacologic methods for promoting sleep tend to be more effective in the long term than sleep medications. The sedative hypnotics that are covered in your pharmacology textbook under Chapter 21, the central nervous system depressants, begin by discussing the sedative hypnotics class, the barbiturates. Those were used from about the early 30s all the way through the early 70s as the primary class of drug that was used for sedative purposes and also as hypnotics or sleeping medications. That's no longer the case because when used for those things, for sleep, for decreasing anxiety, relaxation, they have some very serious problems. So you don't see them used as sedative or sedative hypnotics for sleep anyway. The primary way that they're used now is in for anesthesia applications as adjunctive medications for anesthesia. But there's also one that's still used for an anti-seizure medication, and that's phenobarbital. So the sedative hypnotics, the old barbiturates now, have been replaced by the benzodiazepines and the non-benzodiazepines. The benzodiazepines were introduced as anti-anxiety medications back in the 60s, and through the late 60s and the early 70s, they really replaced barbiturates in their use as a sedative and sedative hypnotics. Chlordioxepide, I didn't pronounce that right. I can't pronounce that one. Librium was one of the prototype benzodiazepines that was developed as an anti-anxiety medication. It's still used for that. It primarily is used now, in my experience, for treating patients in alcohol withdrawal to prevent the development of delirium tremors. So the benzodiazepines are used for sleep, but they're primarily used as an anti-anxiety drug or a minor tranquilizer. They include alprazolam and astazolam and lorazepam. There's several others. The two that you really need to know about are alprazolam and lorazepam. Another benzodiazepine that you should learn is citalopram. Those are all used quite commonly for their anxiolytic effects. But they all are also used, prescribed at times, for sleep. Particularly, I've seen Ativan being prescribed for that fairly often. These drugs are not without problems. They don't have as many problems, much fewer problems as the barbiturates, but they still are a controlled substance, Schedule 4. They do have the potential for abuse and some of the other problems with the Schedule 4 drugs. More commonly used for sleep than the benzodiazepines are more recently developed drugs. One of the most common ones is zolpidem or Ambien, and a couple others that are also used are zolpidem and zaleplon. They are used on a short-term basis. For example, zolpidem is recommended to just be used for 10 days, not for longer periods of time than that. They're very effective in inducing sleep. Zolpidem in particular is good for that, but it's not really good for helping a person stay asleep, although there is an extended release form of it that is prescribed also that helps a person not only get to sleep, but to stay asleep. That's zolpidem. And you may have heard that that zolpidem can cause some behavioral problems during sleep, like sleepwalking, other sleep behaviors, even sleep driving, and also can cause amnesia for things that might occur during sleep. So that can be a problem, and patients need to know about that as part of the education when they're taking that medication, that there is a possibility of having some behaviors like that that are a real safety issue. So for sleep, the medications that are used currently are the benzodiazepines, not very often, but sometimes, particularly alprazolam and lorazepam. The non-benzodiazepines, like the newer developed drugs like zolpidem and zopiclone and zaleplon, or Sonata or Lunesta or Ambien. Those are the brand names for those drugs. One thing, you will see these advertised a lot. And so there are patients that are going to be on these for the time being, and probably the one you're going to see the most in hospital settings is the zolpidem. Melatonin agonists are another class of medication that are used for sleep, and there's only one that I'm aware of that is currently approved by the FDA for use for sleep, and that is rameltion, or Razorem. As a agonist, it targets melatonin receptors. It's not melatonin, but it targets their receptors and activates the melatonin receptors just like melatonin does. So it can help regulate the circadian rhythm and induce sleep. It's effective for that, as is melatonin, but they're both rather short acting, so they don't necessarily help a patient stay awake once they're asleep. There are some over-the-counter things that are used for sleep. Probably the most common one is diphenhydramine or Benadryl, which is actually the active ingredient in most of the over-the-counter sleep products. Kava Kava and valerian are an example of two herbal supplements that are used for sleep too, and they do have some problems. So just because they're herbal does not mean that they're completely safe. So as a review of what we've covered in this unit, I just want to say that the content of this unit is covered well by the readings that are listed in the learning resources in your content guide, so make sure that you study those well. We reviewed what we've covered here is the place of sleep in Maslow's hierarchy of human needs, the physiologic process of sleep, the internal mechanisms that regulate sleep, sleep hygiene, sleep requirements for health, factors affecting sleep, sleep disorders, sleep apnea, sleep deprivation and the physical and psychological signs and symptoms of sleep deprivation, assessing for sleep, nursing diagnoses as related to sleep, non-pharmacologic and pharmacologic interventions to promote sleep. Thank you.